Going back to that early part of March, what was it like when that first COVID patient came into ICU?
It was the week before had been eerie. We'd done a lot of reorganising of the hospital. We'd managed to move patients out of any areas, send anyone home that could go home, and we'd pretty much cleared the ITU ready for COVID patients. Our pre-existing patients we moved to another area, so we had an empty intensive care unit essentially ready to take any incomers, and we knew they were coming, but there was a terrible feeling of dread and anticipation because we knew it was coming, but it was a question of when. And at that stage we knew a lot of the theory behind COVID, and we knew how the patients had been managed in other hospitals, but until you actually manage a patient for yourself, you need to get a feel for the illness and a feel for the disease and how patients react to that. And that's one thing we've learned a lot from the last 70 patients that we've had in, is we're getting, I wouldn't say we're there, but we're definitely getting closer to understanding the best way to managing these patients. And it's quite different in some ways than managing a patient with something like ARDS or severe respiratory failure that we're very used to looking after.
In what way is it different?
Well, a lot of the usual rules don't apply. So certainly with people with ARDS, they get very leaky lungs, they get wet lungs. So we try and keep the amount of fluid that we give them down to keep the lungs dry. That doesn't always work in COVID patients. The other thing that we do is there's a certain type of ventilation where you use a lot of what we call PEEP, which is positive end expiratory pressure, which is essentially leaving some air in the lungs between each breath. So your lungs are a bit like a child's party balloon. The first few puffs it can be quite difficult to get air in, and once there's some air in it, then it's much easier to inflate. Well, the lungs are the same, so keeping them open with PEEP and then putting a breath on top can often help. But again, very high levels of PEEP, which we often use in patients with ARDS and other respiratory failure, doesn't always apply and doesn't always work terribly well in patients with COVID, and it can actually cause a lot of trouble with their hemodynamics, so their blood pressure and their blood flow as well.
And COVID patients are in intensive care for longer, you were saying?
Absolutely, yeah. I mean, so your average length of stay across most intensive care units is somewhere around 3 to 5 days. The COVID patients that we've seen have all been in, for the most part, for a good 2-3 weeks. And so the length of stay is longer, and the progression of the disease is much more protracted than we've seen before. Yeah.
In our last interview, I asked you how people die from having coronavirus. How do people survive it in intensive care?
The key thing in intensive care is your direction of travel. So it takes these patients a long time to get better, but as long as they, and they all reach a rock bottom, which could be at a different place, but they will all reach a worst case point. And then as long as they start to improve from there on, or even just stay the same, as long as there's an incremental improvement or just a plateauing out of their condition, then those are the patients, largely who we stick with, and hopefully they will go on to survive the illness. The patients who don't survive it becomes very clear quite quickly that they deteriorate and they continue to deteriorate, and you cannot arrest that deterioration. There's no plateau, there's no levelling out, they just continue to get worse and worse and worse. We've also had a number of patients who get worse and worse, they plateau, and then they never really start to regain any ground. And in those situations, those patients have often then developed further complications which cause a further deterioration, and that can be very late on. So we've had a couple of patients who've actually done quite well and then have developed further complications, in particular cardiac problems, which is something that we see in the later stages of the disease where the virus can actually attack the heart. There's a huge inflammatory response which is governed by the immune system, that your immune system goes into overdrive, and that can be seen with a number of biomarkers, and that's usually accompanied by collapse of the cardiovascular system, and that's also another late sign. But these things don't happen for 2 or 3 weeks, which is very unusual. Usually you know where you are with an ITU patient within a week, which way they're heading.
And at its crudest, ventilation is fundamental to saving these patients.
Yeah, all the patients we've had on intensive care have been ventilated invasively. Normally in ITU we have lots of patients requiring respiratory support, but some of them will need invasive ventilation, so put into an induced coma, endotracheal tube into the lungs and then hooked to an invasive ventilator. Often we'll have patients who only need non-invasive respiratory support, so that's the same thing that they gave the Prime Minister when he was in ITU in London. We've been very lucky in that we've been able to do all our non-invasive respiratory support off intensive care.
We've seen a lot of patients ending up with tracheotomies. Why is that?
When you go on a ventilator to start with, you have an endotracheal tube put down. Now that's a piece of plastic about the size of a snorkel. It's about a foot long. Goes through your mouth, down the back of your tongue, through your vocal cords and into your lungs. As you can imagine, that is not very comfortable. If you've ever drunk a cup of tea or a glass of water and it's hit your vocal cords, you know how much that can make you cough, even a little drop of water. Well, if you imagine having a pipe the size of your thumb sitting in between your vocal cords, it's not very nice. Most patients will need to be quite heavily sedated in order to tolerate that. The problem with that is when you're very heavily sedated, you don't move around. You're unconscious, basically. So you become very weak very quickly because you're not using any of your muscles, and that includes your breathing muscles. The longer you're heavily sedated, or sometimes we use a muscle relaxant to actually paralyze the patient to stop them from coughing, the weaker they become because the muscles are not being used at all. So that's a problem if you have an endotracheal tube in for an awfully long time, that you can get weak. And also it's a conduit, it's a way in for bugs, bacteria from your teeth, from your nose, stuff that you've regurgitated can actually get down past the little cuff on the tube and get into your lungs and cause secondary pneumonias called ventilator-associated pneumonias. And so for every 10 patients you put on a ventilator for 10 days, one of them will develop a pneumonia because of that foreign body down in the lungs. So after about 10 days, if you're still needing invasive ventilation, the best option then is to do a tracheostomy, which sounds dramatic, but essentially we make a small cut in the front of the neck and the tube goes directly into the windpipe. It's a short tube and it goes below the vocal cords so they can do what they normally do, which is act like a trapdoor and actually stop stuff going down the wrong way, so you preserve that safety mechanism that you've got to stop food or saliva or anything going down into your lungs. It's much more comfortable because it's not in the patient's mouth, it's not down the back of the tongue, which makes them gag. It goes straight into the front of the neck. So very often the patients aren't aware that they've got them in, so you can desedate them completely. They can be wide awake, they can still be ventilated, but they can move around naturally. It's a much more comfortable thing and it reduces the risk of those secondary pneumonias, those ventilator-associated pneumonias. It's not without risk, a tracheostomy, because there is a lot of important clockwork in your neck and you're having to do a small operation on it. But once it's in, it's very well tolerated. And when you're on very low levels of support, you can actually put a thing called a speaking valve on a tracheostomy that allows the patient to breathe in through their neck and out through their mouth, which allows them to talk. And because the tongue and everything are not affected by the tracheostomy, you can eat and drink as well as you start to recover.
What impact can this type of intensive care treatment have on coronavirus patients in terms of their physical and mental state?
So anyone who spends a long period on intensive care, either because of coronavirus or because of any other pathology, there are a lot of problems that come as a result, as part of the recovery. And I'm sure I said this before, that the stay in intensive care is really a very small footnote in the full story of the patient's recovery. So having been paralysed or deeply sedated for weeks, and also having been in what we call a catabolic state, where your body really wants protein, and what it does is, doesn't matter how much you feed them, it needs even more protein, so you start to break down muscle. So you get really, really dramatic muscle wasting. So patients are often very, very weak when they wake up. They can't lift their arms off the bed unaided. They can't sit up because their core muscles become wasted, and a lot of them can't actually do sufficient breathing for themselves because their breathing muscles they haven't used because the machine's been doing the work. So they're incredibly weak and vulnerable, and that rebuilding that muscle takes an awfully long time. So being able to talk again, it involves lots of speech and language therapy. It's the role of the occupational therapists and the physiotherapists to actually get the patients moving again, get them using their arms and legs and their hands. This is a slow recovery. So the physical recovery is one that takes a long time. Lots of people will get back to their baseline function, but it might be months and months. We can talk up to a year sometimes before you're really back where you were. And there will be some patients, particularly those with pre-existing conditions or patients who are frailer to start with, they may never quite get back to their baseline function again. So they will always be maybe slightly weaker, maybe needing more assistance to walk, a stick or a frame.
So that's the
physical side of it, yeah. Mentally, there's a huge amount of things that you need to recover from. So a lot of the patients, because of their illness, there are lots of factors that contribute to this, but partly some of the drugs we use, partly some of the factors of the illness cause a condition called ITU delirium, which is characterized by disordered thinking and an inability to concentrate. And that, again, it can cause very frightening hallucinations, very intrusive thoughts. Patients can slip into a fantasy world where essentially they are haunted by sort of persecutory delusions. So they think that there are gangs of gunmen after them, or then the nurses are conspiring to kill them, and this is very, very common. That in itself is very distressing for the patients, but that disordered thought process can be for a prolonged period of time. They say that if you do develop ICU delirium, your IQ, your sort of baseline IQ, will drop by between 10 and 20 points from its normal, and sometimes that never gets back to normal again. So it's almost akin to having a slightly mild dementia or some long-term cognitive defects afterwards. There are huge body image issues because you've changed beyond all measure. You've lost weight, you've lost muscle. You're coupled with the delirium as well. That can cause depression in a lot of the patients. Post-traumatic stress is common. All sorts of psychological problems, which again can take months and months and sometimes never clear altogether. We have a team of psychologists who are providing a huge amount of support to patients as they come to terms with the new reality of their life.
How long do you think it's going to take for many of these patients coming out of intensive care who've had coronavirus to fully recover?
Well, I think with help they will fully recover, but I think it could be up to a year in many of them. So the NHS must do everything it can to rehabilitate these patients.
Is the NHS equipped to deal with such a large cohort of people coming out of intensive care?
We've been behind, I think, over many years in terms of ITU rehabilitation. A few years ago, we'd pat ourselves on the back when someone like Scott leaves ITU, and we would assume that was the end of our job. We've got much more switched on now about the ramifications of all of these things. And the Intensive Care Society, part of the standards for all intensive care units is that they have access to all the right allied health teams, such as occupational therapy, speech and language therapy, psychology services, follow-up services. So more and more ITUs are gearing up towards that, but they're all at different stages throughout the country. So there will be an increased number of patients needing this sort of help. We're not out of this outbreak yet. There are going to be more patients coming to ITU.
Do you worry about this cohort coming out over the next few months, about the ability of the NHS to support them, given all the demands on the NHS at the moment?
We mustn't fail these people. That we've done the NHS as a whole has done an amazing job at getting these people through such a terrible illness, but it would be an absolute travesty if we were just to cut them loose with no further support. So that needs centralised acknowledgement of the burden, and it needs some very good policy making to ensure that it's a service that's available in every area.
You've probably had one of, if not the most concentrated cohorts of coronavirus patients in intensive care in Wales. What has stood out to you?
What stood out to me? So the things that have stood out are the relative youth of the patients. I know I said this to you the first time we talked, that our cohort of patients has really ranged from mid to late 70s to early 20s. But the vast majority of those patients are in a bulge in the middle between the ages of 40 and 60. Or the mid-60s. So I think, there was a lot of talk of comorbidities, of other conditions. It was mentioned a lot at the start of the virus to try and calm people down and say, well, actually all the people dying are people with other conditions. But actually the other conditions are pretty mild, they're pretty innocuous. Someone who's just on one tablet for their blood pressure, someone who takes the occasional pump for their asthma, or someone with diabetes that's normally just diet controlled, so pre-diabetic. These are not people with severe life-shortening comorbidities. They are huge numbers of the population, and something like 70% of the population over the age of 50 has got some kind of medication they're on, be that a statin for your heart or a pill for your blood pressure. And those are the patients we're seeing. So when we talk about comorbidities, it's not been, really severe disabilities or anything like that. It's just been people like you or I who just take, a couple of tablets a day.
Something you were grappling with last time we spoke was trying to find a way to allow families to be with their loved ones, perhaps to say goodbye in some instances. Have you resolved that issue?
To a degree we have. So the NHS in Wales has rolled out a video calling solution very, very quickly, very successfully, and that's been really helpful. We've been able to do face-to-face updates with families, take them iPads to the patient's bedside so they can see their loved ones, and that's been really, really enormously helpful, and it's much more effective than just a telephone call. That's really helped us a lot. And it's taken a long time it was really contingent on us being able to move the patients into a manageable area where we could control the donning and doffing of PPE. We are now able to get some families in at end of life to see their relatives, which is hugely important. There will always be people, however, that that aren't going to be able to come in, and that's because some relatives are in shielded groups, so the risk is just too high. Some patients will die very suddenly or deteriorate very suddenly, so there isn't actually physically the time to get the family members in to see them. So although we've improved the system quite a lot, because of the nature of this illness and the nature of people, we're not always going to be able to fulfill that. So there will be patients who do die without their families there, and unfortunately that will happen more than it would normally happen just because of the pandemic. The situation I found myself in with a young patient was because of that. It wasn't that I physically didn't have the time or the resources to get the family in at that early stage. So unfortunately I had to give them all the news about the death of their loved one over the telephone. I found that very distressing. I mean, I can't imagine what it was like for them. But as a clinician, that's not the sort of news you ever want to give anyone over the telephone. And the nurses and my junior doctors who were on and myself, we sat with this patient and just did what we think we would want for our relatives, and that we held hands and we were all there.
The Intensive Care Society has launched a very hard-hitting campaign highlighting the psychological pressures on staff within intensive care. What toll is this taking on your staff, your colleagues, psychologically?
I think it varies, and not everybody expresses themselves in the same way. So some of us are demonstrative, aren't we? And I will tell everyone if I'm in moral distress, but others will just keep it under their hats. We are used to people dying on intensive care. It's part of the deal. But we've got lots of staff at the minute who work with us. For example, the theatre nurses who normally work in operating theatres on anaesthetised patients. They're working in ITU now for the first time, and this is not their area of expertise. So they're the people I worry about the most. The permanent ITU staff, this is what we do, and we are used to this. But the volume and the numbers of deaths and the relative youth of the patients makes it much more difficult than normal.
And of course, you also are looking at the constant figures surrounding deaths of NHS workers.
And that's the most frightening thing, I think, is that there are well over 100 NHS workers have died now. A lot of them from BAME backgrounds as well. I'm not sure if we've quite worked out why that is, but a lot of our best and most senior doctors and nurses are from BAME backgrounds. They're not that dissimilar to the patients themselves, and I think that's been the scariest thing for the pandemic. Is actually most patients you look after in ITU, they're ill, they're ill, but it's through terrible circumstances, but it's not circumstances that necessarily apply to you. But in all of these patients, it could easily be any of us. And and you can catch it from the patients as well. So I think that's a real change in the patient group for us, is that we're not safe from this by any stretch. I've had it. Thankfully I had it mildly, but a lot of my colleagues, they're the same age, they're the same ethnicity, they're the same weight as a lot of our patients. I think that makes it all the more frightening for people. And we have had some healthcare workers come in. We've had a couple die, and that just hits it home. So I think it's that constant uncertainty and that constant fear that one day it might be one of us. I think that's probably one of the reasons why there's such trauma and moral distress. If you look after someone normally with a severe pneumonia and multi-organ failure from sepsis, you know what to do. Sometimes they die, sometimes they survive, and it's great. But you have no risk of catching that condition off those people that they've just got because they're unlucky, unfortunately. But nowadays, there is a real tangible risk from all the patients as well. And I think that compounds that. Everyone wants to do their best, everyone wants to look after the patients as best they can, but it's compounded by the fact that actually it could at some point be one of us in that situation.
There are some pretty stark figures suggesting that the virus is not affecting people equally, especially those from a black and ethnic minority background and those from a socially disadvantaged background. Do you think we are doing enough when it comes to health inequalities?
There have always been big health inequalities. I can only speak for South Wales because that's where I work, but there's always been massive health inequality here. It predates Thatcherism, but it certainly was made worse during the closing the mines. There's widespread unemployment up the valleys now, and the life expectancy as you drive away from Cardiff or you drive away from the Vale of Glamorgan and you head up towards Merthyr, it falls in terms of life expectancy by about 4 years as you go up the valleys, in terms of total life expectancy for men and for women. But there's also, in terms of disease-free years, there's a drop of about a year of life for every mile you go up the valleys. So there's always been a big gulf between the health of the richer and the poorer areas. I think COVID is just highlighting that, because we can see that in those areas with poor socioeconomic background and lots of chronic health problems who've always been disadvantaged, it's really shown very starkly now by the death rate there. The death rate's much higher, and it is linked to social class and housing and health.
And the lesson for us all?
Absolutely, it underlines it all. And it's something that needs to be looked at very, very carefully, and I think it should really, I'm not a policy maker, but if I was, we should be doing something to address that divide, and whether it's funneling money into the areas that do have the worst outcomes to try and level the playing field for people. I don't know, but there is definitely a big gulf between the richer and poorer areas and the working and the non-working areas, and that's really shown very starkly now by death rates from COVID.
What do you see as the main challenges ahead for the NHS in the months to come?
I think the trickiest thing that we need to get our heads around now is how we can safely restart elective operating. Just as the impact of the pandemic started, we did a few urgent cancer operations because we wanted to get them done, and a couple of the patients got COVID while they were in the hospital, and although they've all gone home now, they had a very rough few weeks. There are lots of people out there who we cannot forget about. We can't let COVID be the only headline that's out there, and there are lots of people waiting for really urgent operations and for cancers and things that cause them all sorts of trouble. We need to be able to get them going again, but it's finding a way to do that as safely as possible, maybe putting everybody into a clean site possibly, or opening different sections of the hospital for different things. I think that's going to be our next big challenge, and I'm not sure what the best way of doing that is, but it's going to need some very careful thinking. But I think that if I was sat out there worrying about when my operation that's been cancelled was going to be, that would be the first thing on my mind, is how are we going to do this safely so that we can get these operations done, but that we can get people home without giving them any risk.